Thank you, Jake, and thank you everyone for having me here. It's a joy to present here on ITP. I was asked to present on ITP and young people, growing up with ITP, a teen-friendly guide to thriving. So I've taken this a little bit differently. I understand the majority of the audience are not teenagers or adolescents. We have people that have walked from all different paths. I know we've got some teenagers and adolescents here. But we've got people here that may well have developed ITP in their adolescence. We've got people here who may be caring for people with ITP, and we've got medical people who may well be looking up after this age group. So what age are we actually talking about? So this is very ambiguous. I mean, the life is a chronic process. We have children, then we have this developmental age of adolescence where people go through developmentally appropriate significant aspects of their life to become adults and independents. But in reality, we're all children at heart. We all, when you're diagnosed with a chronic illness, I'm sure many of us, being such the social creatures that we are, have wanted that network around us, wanted our mum. I read a post just yesterday, I think, on social media with someone with really bad flu, and they just wanted their mum around. So I think a lot of these concepts can be extrapolated across the life form. So before we can understand how we can help these people thrive with ITP, how we can help our young population who have ITP thrive, we must understand what the actual problem is, who the team is that can help them, because this is something that we help them navigate as a team. We don't expect the young person to go through it by themselves. We expect us as the clinical team, the nurses, the parents or caregivers, the siblings, the whole family unit, and the affected young individual to go through this. And I propose that navigating ITP in adolescence poses many more problems than just those from ITP. It's a complex interplay between the actual ITP and the developmental process of adolescence. So very quickly, we know what ITP here is, everybody here knows, but what is it in adolescence? We know that it affects, we don't have great registry data, particularly not from Australia, in terms of what the actual numbers are per year, but some studies have shown us that it's about 4 to 10 per 100,000 per year, and 1 to 3 of those are adolescents. This equates to about 250 to 600 new cases of paediatric ITP per year. Many, and you often hear paediatric ITP is a different entity, it just gets better, which I debate. But 65% of these will actually recover in the first 6 months. A further 10% will be expected to recover in the next 6 to 12 months, but that leaves 25, potentially up to 30%, depending on what data you're looking at, that go on to become chronic. And chronic is defined as more than 12 months. Some of these ultimately do recover over the next 1 to 5 years, and some will continue to have ITP much longer than that. We certainly know that our adolescent population who develop ITP are more likely to become chronic ITP. So when we quote these figures, we're quoting all comers in paediatrics, but actually we know our adolescent population are more likely to go on and become chronic. And certainly the risk of bleeding, as we've all talked about, it's certainly not congruent to the platelet number. I have many patients with single-digit platelet numbers that don't bleed and many patients with higher platelet numbers that do bleed. So it's a complex entity. And as we also know, there is a risk of clotting, and that risk starts to become apparent in the adolescent years. We don't really see the risk of clotting prior to adolescence, pre-puberty, but with those additional risk factors, I've certainly had a number of patients that have had blood clots as well. So this, and I think in the interest in time, I won't go through each of these patients separately, but ITP is very different. Each and every kid has a different presentation. I've seen 6-month-olds with single-digit platelet counts who really get a particular rash and then ultimately recover. 2-year-olds that just bleed and bleed and bleed and are always covered in bruising to the extent that the parents don't want to take them to the supermarket because they feel people are looking at them funny. Unfortunately, we do have a very small number of patients that have had intracranial bleeding, which can be quite concerning. Blood in the urine, and then some patients that just have a very insidious history who may have had fatigue for years and have a blood test eventually and find out that they actually have ITP. So our risk factors to becoming chronic, which a lot of, when I'm meeting a new patient with ITP, a lot of people want to know when it's going to get better. Will I have chronic ITP? And unfortunately, without that magic ball, I can't tell patients that, and that is one of the struggles of paediatric ITP and adolescent ITP, because we just can't tell them. There's no biomarker that will tell us who will get better, but we do have some indications who may or may not. Some things that we can sort of counsel them on. So we know if you're 11 or above, it is more likely, you are more likely than the 2-year-olds, but then I also have plenty of 2-year-olds that have gone on to become 5 or 6-year-olds and still have ITP. And I've had 12-year-olds who have had ITP for only 3 months. So yes, there's a little bit more chance, but we can't give you an exact number on that. We know, and there's data to prove that patients that have a higher platelet count when they're diagnosed certainly are more likely to become chronic than those that have the sub 10 or the more severe platelet counts. Those that we don't identify that clear precipitant. In paediatrics, we often find that a child's had a virus, 2 weeks later, they're covered in bruises and petechiae, they come in, they get a diagnosis of ITP. But those without that clear precipitant, and we know kids are exposed to viruses all the time, so maybe they did have a precipitant and their immune system just got on with it, cleared the virus, but also developed ITP. Of course, those with secondary ITP that have other autoimmune conditions, lupus, Crohn's, all those other things, of course, they're more likely to become chronic. And females, of course, well, not of course, but females are more likely to become chronic. And certainly looking around the room, I do see a higher proportion of females than I do males, but there's probably multi-factorial reasons for that. So what is the actual risk? Why are we talking about this today? So the risk of bleeding in paediatrics is quite low, but when you look at the numbers of the people that are diagnosed, 1 to 2% will suffer severe bleeding. That's still a reasonable number of patients that are going to get severe bleeding. And it's all well and good to be very reassuring, and we are very reassuring that the chances of something like an intracranial bleed is very, very low. And, if we know the symptoms, we can usually prevent that. The reason why the young people, the family unit, everybody is worried about it is because that risk is not zero. But then Danny said the risk of doing anything in life is also not zero. But it's that balance of there is an increased risk, and how do we balance that to just go on and live a normal life? And severe bleeding is not just brain bleeding. I recently had a patient who had severe bleeding from losing a baby tooth. And bled a lot, dropped her hemoglobin, landed in ICU. So, severe bleeding can occur in other ways as well. And I've certainly had plenty of paediatric patients with nosebleeds that have caused quite significant transfusion needs. Fortunately, there are some signs. So again, it's not congruent to the platelet number, but we know those that have got the more significant mucosal bleeding, the bleeding in the mouth, the bleeding in the poops, the bleeding in the urinary bleeding, and the ones that get nosebleeds are more likely to have those more sinister bleeding. So they're the population that we're more focusing on for treatment. And then again, looking in an adolescent population, what are the other risks that we and the family unit and the patient themselves worried about? So we're also worried about clots, and the longer that I work, the more clots I have seen in the setting of paediatric patients, and a lot of people don't appreciate that risk. It is only very subtle above the baseline, but it's certainly still there. We're worried about fatigue. These patients are going through a very important stage of their life where they have many important requirements: school, academic, sport, and we know that ITP makes them more fatigued. And in many cases, the doctor's not asking about that or acknowledging those symptoms. So that is certainly something that's very relevant to them. And we're worried about screening for additional autoimmune conditions that might not be present at diagnosis but can come on down the track. In a lot of my talks, I talk about how I do think ITP is dismissed somewhat in the paediatric population, and I think that's a little bit because in adults, it's more than 70% or more than 50% that are going on to become chronic. And in kids, it's the opposite. So whilst not everybody goes on to become chronic, there still is a significant population. And these are just some of the many things that I've heard. And really, that's not validating what it is for the family, what it is for the child going through this. Many can just go on and do life as normal, but sometimes we do need to make some adjustments, and we need to help that young person get through that. So changing tact a bit, not talking about ITP, but we're talking about young people. We're talking about that transition between paediatric patients and adulthood. And this period of time is called adolescence. So what is adolescence? So the WHO definition, the World Health Organization, defines adolescence as a phase of life between childhood and adulthood from ages 10 to 19. It's a unique stage of human development and an important time for laying down foundations of good health. There's been further studies that have actually suggested that this structural and functional change that occurs within the brain actually continues well into some patients' 20s and even 30s. So this period of developmental change before you get a more static couple of decades within the brain really is going on from puberty, which is easily as early as 10, right into people's 20s and 30s. So we're not just talking about paediatric patients, because a lot of those are actually managed in the young adult centres. Adolescence affects how they feel, make decisions, and interact with their world. So what are the developmental tasks that these patients need to go through, or all adolescents need to go through? Everyone does this in their own time, in their own way, some a little bit more chaotic than others. They develop their identity, they develop autonomy and independence, they develop deeper connections with people in their lives. They learn how to be emotionally mature and regulate their emotions, different to those in toddlerhood. They go through cognitive development where they learn critical judgment, planning, and controlling impulses. And I suppose this is one that there's great evidence to show that this certainly isn't fully developed in early 20s. They go through body image and self-acceptance. In this time, their bodies are going through rapid changes. They're, accepted of their bodies, and then all of a sudden it completely changes. So they go through a developmental process to accept their body as their body, and they develop their sense of morals and moral compass. I went to a presentation earlier this week by one of our adolescent physicians. There's a whole specialty on adolescent medicine, and I thought this was great. He described how, as medical doctors, we deal with a lot of complicated situations. We deal with some complex situation as well, but we deal with a lot of complicated situations where there's many parts to consider, but this is orderly, it's predictable, there's cause and effect. You give this medicine, this happens. And if you've got the technical expertise, you can normally get through that degree of complication. It's a linear, you can see that circle there, one thing leading to the next. There's good evidence to show that adolescents are complex organisations. So complex organisation is when there's lots of interconnected aspects that are not necessarily causing predictable linear approaches. And management of these individuals, working with these individuals, whether that be in the house or in the patient, requires adaptive leadership, because one day something could be okay and the next day it's not. So I thought that was a very good way of looking at adolescence, because I think those of us that have had teenagers, or those that are a teenager, can relate to this. So this is a line I found online, and I thought this is quite good. So you're trying to get from pediatrics to adulthood, but there's a lot of up and downs in the middle, a lot of roller coasters before you get there. So normal teenage habits, as I'm sure many of us know, they're actually physically wired to have different sleep patterns than us. They need more sleep, and they're actually physically wired to go to sleep later and wake up later. Mood swings are very common, and of course that's all the hormones, all the changes as they're going through this developmental impulse and risk-taking behaviour, as we've talked about. They're wanting to be more private, and they go through phases of rebellion and testing the boundaries, and this is all completely normal. So what does adding chronic illness into this look like? So actually, whilst ITP is quite rare, in our adolescent population, up to 15 to 20% of adolescents have a chronic illness. A chronic illness is defined as something for more than 3 months. Many of them will have lifelong illnesses. Many of them will have illnesses that are temporary. And chronic illnesses poses challenges to all of those developmental milestones. Often there's physical restrictions on what they can and can't do. It affects their body image. Some patients have significant scars or changes in their body. Interestingly, though, in terms of getting from one spot to the other, for those that are cognitively intact, then there isn't actually a delay in going through the adolescence. And in some parts of those developmental milestones, they can develop increased emotional maturity and go through some of those milestones a little bit quicker. because they're forced to take on responsibilities that their peers that don't have chronic illness are not. Having an adolescent in the family who's got chronic illness, of course this poses stress to the family. It focuses on the child's illness with often unintentional neglect on other aspects of that child, such as their schooling, their sport, the normal aspects of being an adolescent. Life can become about the illness more so than about just everything, and can take some focus of other family members as well. The additional stress, so those normal behaviours such as risk-taking behaviour can become an increased concern for these families. So I use current topical example, using e-bikes. So riding an e-bike without a helmet, that's obviously very stressful, I find, for all teenagers because they're very high risk. But, you know, if you're adding in a bleeding disorder or a risk of bleed, then that's heightened stress for that family and an extra challenge to have to deal with. And the parents' well-being is often impacted. And there's often a lot of guilt that comes from one person having an illness and another person not. And that's something that we can address as well. So normal adolescent behaviours such as forgetfulness can actually have a detrimental effect on the illness, of course. So taking medications, not wanting to come to appointments. I had a patient who I haven't met just this week not want to come to their appointment because they just wanted to do their normal life. Specifically, so we've talked about chronic illness, but specifically ITP, why is it so challenging in adolescents? So there's lots of uncertainty in ITP, and I find it quite challenging when I sit down with a new patient. I go through the new diagnosis in my half-an-hour appointment with the family and the affected person, and I can't tell them, like, if this is going to get better next week or if they're going to have this well into their adulthood. I can't tell them. I often get asked, can I be a pilot? I can't tell them all of those questions. There's a lot of uncertainty. Will they respond to the treatment that I recommend? We can give them percentages, but we don't know if there's no biomarker, there's no test I can do to say you will respond to avatrombopag. So let's start you on that. Appointments is time away from everything else in life. They're doing so much. A lot of our teenage populations are involved in so much extracurricular activities, and having to come to appointments takes time out of doing a blood test, takes time out of everything. Risk-taking behaviours can, again, cause increased risk. Rebellious behaviours can cause increased risk. One of the really biggest one in adolescence is the menarche, the development of the menstrual cycles. Unfortunately, I've seen many patients with their first period being admitted to the hospital for a blood transfusion, or sometimes that's the exposing fact for the ITP. And I mean, that's a very, sensitive time in a lot of people's lives. It can be quite traumatizing to have that. Steroid side effects, I mean, this is an audience that I'm sure all understands, as I have been quoted to devil's Tic Tacs. These steroids pose a lot of problems for teenagers. Changes in their sleep when they desperately need their sleep, changes in their mood when their mood is already up and down going through this roller coaster of adolescence. Changes in their diet, weight gain, accepting that, their bodies, there's so many side effects of them. Fortunately, our guidelines in paediatrics, we're not using a lot of steroids regularly, but some younger people that are above that age group, I heard of a grade 12 student that had been on steroids for 6 months recently, so I can only imagine how that impacted her time. And then, of course, the fatigue when they're trying to do all these other things. So then the model of care in adolescence, how we treat these patients, also adds some additional confusions. So in paediatrics, and we're all from different centres here, but many of the centres I've worked at have a similar model. It's a bit different in every state, but often patients with ITP, if you're a child less than 16 or less than 18, depending on where you are, you'll be referred to your local general paediatrician first, who is not necessarily a specialist in ITP. And that model comes from most of these patients get better. And then when the ITP's been around for 6 to 12 months, they'll be referred on to a haematologist. Some are just, if the paediatrician's not comfortable, are just referred straight to the haematologist, or they do a shared care situation, which often works quite well. And then when you become 16 or 18, or you finish school, or you start a trade at some time, you are transitioned into the adult service. And that's when you really are expected to be autonomous with your care. We do have adolescent medicine specialists, and they can help us deal with the more complicated and the more complex patients that we have. This is an evolving, so this is a whole subspecialty. You can be an adolescent medicine specialist. In New South Wales and Melbourne, they have quite a lot of them. In Queensland, we have 5. Perth also has a lot. I don't know the numbers in every other state. But for those patients that are complicated, we can involve an adolescent medicine specialist to help us deal with some of those normal adolescent issues and how they are feeding into the illness. And that's just quickly some of the other adolescent things that we think about. And we won't go through the whole adolescent medicine specialty right now because I am talking too much. So who can help these people thrive with ITP? So this is very much a team approach, as I'm sure it is with adults as well. If you've got ITP, I see people with their families here. It's great to have a team that's involved in your care. So the medical team, the nurses, the doctors, the family unit, the young person, and anyone else that they want in their circle. How can we as medical people, but also as parents and families, help these patients? So again, we've got to define the problem before somebody can begin to deal with it. So education. And I alluded to the fact that for my first patients, I get a 30-minute appointment. So I meet the patient, I take the full history as to what's been going on and whatever other medical history they have. And then I need to explain ITP, its treatment, in an age-appropriate way with the child and also with the parents as well. It's not very long, and I usually go over time, so I'm sorry for everyone else in the waiting room. But we also know in that meeting, and there's evidence to show that people, when they're learning something new and they're so overwhelmed, they will only take 3 pieces of knowledge from that. So there's only so much education you can provide then. So it's really important to have additional appointments quickly to reiterate that and allow for further questions, to encourage the young person and their family to be writing down those questions, but to provide additional resources so that they can get that education elsewhere and potentially in a more appropriate lay fashion. And we'll talk about this in a moment. And of course, the patient support group, which is why we're all here. And in you'll notice there's not a lot of adolescents here, and that's something that I really and working with, my patients, I think a lot of it is that the knowledge isn't there. I think the patients and their families would really benefit from coming to things like this. And we have similar models in other diagnoses. So I'm also involved in haemophilia care, and actually patients love coming to the conferences. So I think as time moves on, this group will expand and we'll be able to support those people. And then our younger people will have an avenue for being able to meet other people, which they always report as being very beneficial. As they're going through this adolescent roller coaster, it's really important as parents and as family members that we do it, empower them in the decision making. But it's also a little bit about, so I said here, read the room, because I'm going to use an example. Recently, I had one of my adolescent patients come, and it was, I think, the second time I'd met her. She has ITP, and she sat on her phone the whole time. She just sat there on the phone. Her mum was very engaged in the conversation. She didn't look at me and just sat on the phone. And it can be very easy to get frustrated with that. They're not taking responsibility, not wanting to learn. But I also wouldn't expect a 4-year-old to sit down and listen. And I suppose what she was telling me and what she was telling her mum is she's not emotionally ready to deal with it. She wants her mum to take that responsibility right now. And that's okay. So sometimes they're ready to learn, and sometimes they need you to be there and to help. But as time goes on, it's about giving them more power and more autonomy, because when they do go to adult land, they will be expected to be in charge of their care. And you might be invited as a family member, but the decisions will be that for the young person, even if they haven't gone through all of that brain development of adolescence. Once they're 18, if they're cognitively appropriate, then they will be responsible. So I slowly try and increase how involved they are in their care. and start talking to them about what it's going to look like in the next phase earlier rather than later, as opposed to getting to your last appointment and saying, oh, you're turning 18 next week, so you're going to go off to the adult centre. It's important to start talking about that early. It's important to validate their experiences and figure out what's the problem for them. Is it that they want to play this sport and they can't, or they perceive they can't? Is it that they have to have a blood test? Some patients are extremely stressed about having blood tests, and I'm sure some adults are as well. And sometimes, if it's clear that the platelet count, if the child's covered in petechiae, maybe we don't always need to be doing those platelet counts. Sometimes we can negotiate minimising that if that's the problem for them. Obviously, open and clear communication. And it's really important to have contact pathways. We have contact nurses within the paediatric hospital. We have a contact card that everyone gets. There's a mobile and email, and there's always someone on call. And actually, our parents can call us, or the families can call us at any time in our hospital. It's not necessarily the same in every hospital. So again, it has been mentioned, but I think this book is excellent, and I thank Danielle very much. I've had a lot of positive feedback from my patients. As soon as they see it, their eyes light up. In fact, the one that I mentioned with the mobile, she now does talk a little bit more, but as soon as she saw this, she was very excited and started reading it in the room. It really does talk at an age-appropriate way, and it's very easily can go down to 9 or 10-year-olds. It's written in the UK, but it's been adapted for an Australian and New Zealand audience. And I always give patients 3 or 4 copies. Sorry, Danielle, I need a few more. Because I think this, teenagers, we do encourage them to tell their network, their friends, what's going on for them, but they find it very hard. So they can give this to the school teacher, they can give this to their friends. One can sit in the library at school, and they can understand what's going on for them without them necessarily having to take responsibility for explaining it. And it's also got some real life data, so real life practical stuff. Like a lot of teenagers, when they become adults, they want to travel and see the world, and that's very normal. But it talks about travel insurance and really practical things like that, and also just general health and well-being, vitamins and things like that. I thought very good with a focus on health. So what can the young person who's got ITP do to navigate their journey through adolescence and being a young person, but also having this? So again, we accept that this is a roller coaster, and some days you'll want to talk and some days you won't. But as you travel through those teenage years, it's important to become more involved in your care. One thing I find really challenging is when, and this is far beyond ITP, but I do a lot of telehealth appointments, and it makes sense when they're 2 or 3 not to be in the appointment. It's kind of better sometimes, but as teenagers, when you're talking about diagnosis, the teenagers are not getting that information if they're not at the telehealth. It's a bit of a tight balance because we want to keep them at school, we want to keep them doing their normal things, but as we're approaching that second half of adolescence, I think it is important that they start coming to some of their appointments. I mean, just this week I had a patient that's 17, and the mum said, I didn't realise the child needed to be there. Like it's very hard to us to expect them to do well in the adult land if they're not participating in their care earlier on. Communicate openly what your concerns are, because we will have a preconceived, as a young person, as a doctor of a young person, we will have a preconceived, okay, they don't want blood tests, they don't want this, they want to play sport, but we don't know what it is for you. So you can even write that down. You don't have to, if you feel very shy in the appointment or you're feeling reserved, you can write down. I have some teenagers that come and they come with a list of 15 questions or concerns for me, and we just sit down and go through them. And that can be a way so that you don't leave the appointment and go, oh, I didn't ask this and now I'm not coming back for a few months. Of course, so you've got the contact pathways. Let the people around you know if, today I just don't want to talk about this. So again, it's all about open communication. It's important that you're telling your carers what your symptoms are. Not all households talk about periods. Sometimes there's not a mum involved or not a female carer involved. You can get quite sick from very heavy periods, so it's important that you've got a safe person that you can talk to about that. A lot of teenage patients, no matter what their diagnosis, I treat a lot of teenage patients, tell me that connecting with other people with that disorder really is helpful for them. ITP is rare, but it's not super rare. There are lots of teenagers with it. And there's now many ways to meet each other online, social media, even at the hospital. I've had a few patients recently ask me if they can meet other ones of my patients. And now I've had 4 patients meet that way. Of course, everybody has to be consenting to that. But that's a really nice way. And then they go get coffee afterwards or whatever they do. There's a lot of evidence to say that talking to your networks and talking to your friends can help you go through this process. And again, 15 to 20% of kids will have a chronic illness, so they might tell you something that they're going through as well. And again, communicating what's important to you. A little bit, everybody always asks, I thought I'd just quickly touch on this, though I am out of time and may need to leave. No. The reality of risk. So a lot of people say, can they do this? Can they do that? And there's never a clear answer. And that is one time where, yes, we want to empower the young person, but really I try and empower the family unit to make the decision as to, we can guide as to what the higher risk activities are. As Danny said, like, no activity. Walking down the road is not risk-free for any of us, ITP or not. There are certainly, if your platelet count is low, there's certainly activities, really heavy contact sports, rugby, martial arts, I'd prefer not to. But then we also have patients that have got ITP that are playing professionally in those sports. Their ITP is just well controlled. So I do like to empower the family because it's ultimately the mum and dad that are lying awake at night worrying about their child doing that sport. So we give the education and then empower the family to decide what, the family and the young person, what priorities are important. And if they can't do one thing, it's always good to try and find something to replace that. So this is just a bit of a summary. So what is the problem? So we define the problems at the beginning. ITP is a medical condition with no certainty. There's a small but not insignificant risk of life-threatening complications. There are many treatment options. Nobody knows who will respond to what. They may not be able to safely do all activities. And this is all at a time where adolescents are developing and learning how to navigate the world and become individuals and autonomous, moving forward for the next phase of their life. I do find that the paediatric patients do get a little bit dismissed because there's a preconception that they all get better. And this creates a lot of stress for the families. And just going back to them getting dismissed, that also means that clinical trials, we've been involved in some, but we're not involved in we don't have the same clinical trial possibility as there is in the adult world. And adequate management of ITP can allow children to go through this adolescent roller coaster in a relatively or a less chaotic way, but continue on the complex line. So thank you very much for listening. And hopefully we'll have more kids next time.